I got that fire, 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 fire.
Go.
Describe the associated findings in addition to disequilibrium if the cause of disequilibrium involved the following areas of the spinal cord: the dorsal column, the corticospinal, and spinothalamic tracts. How do upper motor neuron and lower motor neuron lesions present differently? Alex?
So I'm going to start by showing the different parts of the spinal cord, and as you can see, this is page 427 of first aid, and there was an errata that you make sure you fix in your book. So the dorsal columns, we're going to think about those in this back area. That's the fasciculus cuneatus for the upper extremity, and the fasciculus gracilis for the lower extremity. And those are going to synapse in the medulla, in the nucleus cuneatus and gracilis. They are sending proprioception, vibration, touch, and pressure. We're also going to be dealing with the STT tract, which is going to be more lateral. That's sensing pain and temperature. And then the last thing we're going to be dealing with is the corticospinal tracts. And so those are going to be dealing with signals from your brain for voluntary motor control. So now I'm going to turn it over to Ulysses.
Okay, so I'll be talking about the STT tract. First, you have the sensory pain and temperature. It goes up and synapses ipsilaterally about two vertebral levels above. Decussates goes up toward the decussates through the anterior white commissure, and then goes up to the thalamus. And there's really we're not sure if there's any connection with disequilibrium in this sense, because usually it would cause loss of pain and temperature on the the ipsilateral side, contralateral side. And but there's no connection to disequilibrium.
So your DCML in your dorsal column helps you. I don't like video.
Okay, I'll take this over. Mike just totally messed that up for us. So your DCMLs, condensed proprioception, runs up your dorsal columns, and it can get demyelinated in certain diseases such as like tabes dorsalis, Friedreich's ataxia, or B12 deficiency. And that will happen on the ipsilateral side. And then with this, with the positive Romberg with the DCML lesion, while with the cerebellar lesion, you would have instability even with your eyes open. And Hugh Gordon is going to tell us about the difference between upper motor neuron and lower motor neuron lesions.
So you have two types of lesions. You have your upper motor neuron and your lower motor neuron lesions, and you can differentiate these based on symptoms. So for upper motor neuron lesions, you're going to spare your sensory, cognitive, and ocular motor abilities. There can be caused by genetic or idiopathic reasons. And yeah, lower motor neuron, polio is a good example. You get fever, malaise, you have nausea. And that's kind of your lower motor neuron. Remember, you kind of just have flaccid paralysis with the lower motor neuron, and you don't have any reflexes. Upper motor neuron, I forgot to say, you get very spastic reflexes when you have an upper motor neuron injury. And then we shouldn't forget Brown-Séquard, where you have kind of a mixed picture, because you're doing that hemisection of the spinal cord. You'll have some lower motor neuron and some upper motor neuron symptoms.
How about Babinski?
The Babinski will be positive in an upper motor neuron and will be negative in a lower motor neuron.
That's awesome. And that concludes Group 2's presentation.